Hey everyone, and welcome to our webinar tonight. It's my pleasure to introduce to you Doug Brown. He's got a 15-page resume. I've boiled it down to a couple of sentences here. Doug is the FRCPC emergency physician at the Royal Columbian Hospital. He's been a search and rescue volunteer since 1996 and is a helicopter and mountain rescue technician with Lions Bay and North Shore Rescue, as well as a ski doctor for Whistler Blackcomb and Mike Weigel. I hope I pronounced that right. Helicopter skiing. He is one of the Canadian Society of Mountain Rescue or Mountain Medicine Diploma in Mountain Medicine faculty, and was the chair of the Medical Advisory Committee for the BC Search and Rescue Association. He has a particular interest in wilderness and environmental emergencies. Was the lead author on an accidental hypothermia review published in the New England Journal of Medicine, and has been featured on EMRAP. And it's my pleasure to introduce Doug. And just before he gets started, Doug has agreed to answer questions periodically throughout his presentation. So if you have questions, please feel free to put them in the comment section. And when Doug pauses and asks for them, I'll go through them and queue them up for Doug. Doug?
Fantastic. Thank you so much, Dwight. And thanks very much to Dwight and Nancy and the BC SAR Support Network for hosting the technology and putting these webinars online and stuff. And to Squamish SAR for basically being the impetus for this talk tonight. So let me just get my screen share going. Dwight, can you give me a thumbs up if you can see the slides fine? Okay, perfect. All right, welcome you guys. It's really exciting to be here. I wish I was up in Squamish presenting in person, but that can't always happen. So we're going to do the virtual thing instead. Like Dwight said, I love questions and I love discussion. So pop stuff into the chat and we'll pause at different times. I don't have any financial conflicts of interest. I make my money by seeing patients in the emergency department and working in the ICU. And then I volunteer with Lions Bay, North Shore, Whistler Blackcomb. I trade doctoring for heli skiing with Mike Wigley's, but I don't have any kind of secret sources of income. Today, we're going to try and run through some inspirational cases. I really like case-based learning. The things I want you guys to try and get comfortable with is understanding who is cold and dead versus who do you need to potentially do a prolonged resuscitation for. We're going to talk obviously about the management of accidental hypothermia, and I want to really bring to your attention the special circumstances of trauma, drowning, and avalanche. And let's start with our first case. So this case actually happened while I was a medical student, and I was actually away in Edmonton doing an ICU elective. But this case was really part of my journey in quite a big way. So this was actually an employee at MEC, and he and a buddy had climbed up the Harvey ramp in winter conditions. So it's like a 45-degree to 50-degree snow and ice slope. And the two of them had separated. The partner was less confident. They were soloing, but kind of in proximity to each other. But then the one fellow kind of pulled away, and the other fellow pulled back. And the one who pulled back climbed back down to the bottom, and the one who pulled away wasn't really seen or heard from. And so the fellow waited at the bottom, and when his partner didn't arrive, he went back to the car and called for rescue. And then our team got there in the middle of the night, and they were doing their whistle blasts, and they found him on the snow about 600 meters from the base of the route. And he looked pretty scary to them. His helmet was dented, he had a bloodshot eye, he had pain everywhere, and he was initially like somewhat coherent. It was a time when our first aid training was really, really, really focused on C-spine precaution, really kind of almost to the detriment of a lot of the other things. And so our team, unfortunately, at the time was really kind of nervous about this guy, and so they kind of like put him in C-spine precaution, and they covered him with some like a bunch of puffies and jackets and things, and they called for help. The 442 was not available, and this was before we had night hoist and all these fun things. So it was a ground team that arrived with the full hypothermia kit. Um, and as they packaged him into this hypothermia kit, he became combative. And then he was bumped down the road, with a stretcher carry, and then transported to the closest hospital. And unfortunately, kind of right at the door of the hospital, he went into cardiac arrest. And then he unfortunately died several days later. And so what I like people to do is to brainstorm, maybe in the chat or maybe amongst yourselves for a second. Just think about what do you think are the possible causes of death. Um, if anybody wants to volunteer, you can. If anybody wants to volunteer into the chat, you can. Um, do we have anybody piping up in the chat, Dwight? You're muted, Dwight.
Yeah, we do. We have Raz who's suggesting brain bleed.
Yeah, that was one of the first things I thought of when I kind of heard about the case. I agree. Is an intracranial hemorrhage. Any other
Yeah.
ideas?
Francois suggests a cold after drop.
Okay, so hypothermia, good bet because we are in a hypothermia talk. Other things that might have one of these sort of major traumas who initially is alive and then later dies. What else is kind of on the differential? Any of our
Nothing
first
yet.
aid keepers?
No other suggestions here.
No other
Oh,
suggestions.
arrhythmia.
Yeah, arrhythmia maybe in the context of hypothermia, but I was thinking more like, could this guy have had an intra-abdominal injury, right? Like a liver laceration or a spleen laceration, and then he slowly bleeds out and then dies. Um,
Rescue collapse by Sean.
Rescue collapse. Again, we're kind of into the hypothermia world, so we'll talk more about that later. Okay. So yeah, so the end result for this fellow was that he actually didn't have that much in the way of major trauma. The bloodshot eye was presumably just a subconjunctival hemorrhage. He didn't actually have major intracranial injuries. He had a broken hip. He had multiple minor injuries, and his family was told that his cause of death was hypothermia. And so this case really struck me because for a few reasons. One, of course, we wish that we're not part of a patient getting colder, right? We kind of hope that when we get to them, we can kind of we can stop them from getting colder and then even slowly warm them, right? So this case happened a long time ago and it dramatically changed what we do on Lions Bay in terms of every hasty team now basically carries with them the materials to be able to do good hypothermia resuscitation and stabilize temperature. So all of our teams now carry some sort of bothy bag or similar, some sort of blizzard bag or similar, and then they always have a stove with some sort of soft kit to be able to fire hot water into a person and deliver heat for those people who can't make heat themselves. So this was a really hard case for us, and it really changed how we approach things. Okay, quiz time. So, if you have pre-hospital traumatic cardiac arrest, so you get hit by a car and you are so traumatized that you have a cardiac arrest, and let's say it happens right in front of like the best hospital in the world, Royal Columbian Hospital, and there's a really amazing trauma team that's right there to take care of you. I want you guys to think of what is your chance of survival. And I want you to put up your hand if you think it's less than 1%. And I want you to put up your hand if you think it's about 10%. And I want you to put up your hand if you think it's about 50%. And the answer is that traumatic cardiac arrest has a very dismal prognosis, and it's almost impossible to save these people. It's slightly better if you have like a stab wound or a gunshot wound and we get you quickly. But if you're hit by a bus or a car and it's bad enough to cause you to have cardiac arrest immediately, then the chances of us bringing you back is very, very low. Okay, now instead, let's imagine we have a patient who slowly got colder and colder and has a hypothermic cardiac arrest. Now, what is the chance we can get this person back? So I want you to put your hands up for less than 1%, your hands up if you think it's about 10%, and your hands up if you think it's about 50%. And Jenny, tell us what's the most popular answer there in Squamish before we reveal.
I think we're a half-half between 10 and 50. Am I right?
Okay, perfect. That is really good to know. So what I am going to tell you is that I believe that the number is 50 to 100% for well-selected hypothermic cardiac arrest patients. And I'll present some data, I hope, later in the talk that tries to back up what I am saying. Okay. So yeah, hypothermic cardiac arrest is a very different animal. And potentially, if treated properly, it can have a really positive impact on outcome. Now, it's not a panacea though. So what do you think about the combination of hypothermia and trauma? Is that hypothermia plus trauma, is that going to increase our survival? Is that going to decrease our survival, or is that going to have no impact? And the answer is actually hypothermia and trauma is a deadly combination. So for your trauma patients, your moderately and even your severely injured patients, if you can keep them at a normal temperature or bring them back up to a normal temperature before you deliver them to hospital, you will dramatically improve their chance of survival. And if instead you even let their core temperature drop by a couple of degrees during your transport and you're getting them out of the field and to hospital, you are going to more than double their chance of death. So this, whereas severe hypothermia patients are relatively rare, minor and moderate trauma patients are very common, and this is one of the lowest hanging fruit for things that we can actually do that can have a big impact on our patients. So if you get nothing else from this talk, I really want you to plan for the patients that you go and take care of, that you can keep them warm and make them warm. Okie dokie. Any questions so far before we get into our first inspirational case?
Nothing in the chat yet.
Okay, perfect. So, lo and behold, this is yet another Squamish search and rescue call. Apparently all my best, it's hard to know if that's the right word, all the most exciting and dynamic search and rescue cases seem to happen in Squamish. Maybe not all of them, but a lot of them. So this was a 24-year-old female who was at the Elfin Lakes hut. And for reasons we won't talk about, she left the hut at about 2 a.m. And interestingly, she became disoriented and disrobed. And about 7.5 hours later, she was found lying in the snow, kind of underneath a tree with agonal respirations. The team, the public, the members of the public who found her were quite special. They were just recreational skiers, but they were a retired infant transport team paramedic, a retired nurse, and 2 or 3, I think 2 other people who were just very, very dedicated to working on this woman. So they did so many things right. One, they noticed as this disrobed woman lying in the snow who was not talking to them, they noticed as they went to try and wake her up that she initially had some respiratory effort. And they noticed that that disappeared as they kind of tried to extract her from this melted in snow area she was in. And they started CPR right away. And high quality bystander CPR is kind of the understatement of the year. Okay, these guys did great CPR. They got a sleeping bag out and had people rotate being beside her, trying to warm her while they were doing CPR. They used a camelback to suction like secretions and junk out of her airway when stuff tried to obstruct her airway. And interestingly, probably the only thing that went wrong in the beginning was it was broken telephone back to the hut because there was no cell service where they were. And so somehow the first call that came in for Squamish SAR was that of a um, despondent person who was missing. And it wasn't until about 1 hour into this resuscitation that an update was provided to the Squamish SAR that actually this was a patient in cardiac arrest. So it just goes to show the first information is never right in search and rescue. This was probably the most extreme example of that that I can remember. Thankfully, both the Squamish SAR was mobilizing, but they also mobilized a number of your teammates who happened to be working on Whistler Blackcomb that day. And so 2 hours after CPR started, but an hour after Squamish really understood what was happening, an ALS team arrives by helicopter from Whistler Blackcomb. And interestingly, they had quite recently listened to this talk and they basically knew this case like right away. They knew what to do. They were on the radio with John Howe, who was the search manager, and they were like, this is this hypothermia cardiac arrest case that we've been told about. We need to get this woman to Vancouver to get her this special treatment. And then, interestingly, as they were doing all the right things to get ready for that, they could not resist to shock VFib and VTAC over and over again, which was fine. But in general, if you have a patient in hypothermic cardiac arrest, do a few rounds of normal CPR with all of your medications or defibrillations as you normally would. But once you decide that it's hypothermic cardiac arrest, you can stop shocking and giving meds, and you can just focus on high quality CPR and good transport. But nevertheless, they had lots of time because the helicopter had to go back to base, fuel up, reconfigure to be able to take the stretcher. And so they had 40 minutes on scene with her after they had arrived. So they arrived at 2 hours. They had 40 minutes on scene. And then we unfortunately had no access to the BC ambulance critical care helicopter. So we had to fly with the rescue helicopter, just an A-Star, all the way to Vancouver. But we can't land at the hospital because it's not a twin engine aircraft. So we have to fly to the airport, and then we have to road ambulance her to the hospital. And so this was her presenting rhythm. So she had course VF after 2 hours of CPR, which again is a credit to the bystanders. Obviously, they wouldn't be able to see this because they were just using an AED, but we downloaded it later. As we talked about, this is what we would have liked to have flown in, the flying ICU. But instead, you guys know the A-Star very well. You have the pilot in the front right there. We have the stretcher laid out in configuration here. One person doing CPR, another paramedic sitting in the jump seat there, giving meds, talking on the radio, trying to help coordinate things. And interestingly, the pilot had never flown to Vancouver or YVR before. So you can just imagine the cognitive load for everybody. So despite all these challenges, she arrives very promptly in Vancouver, and we arrive in the operating room 4 hours after CPR started. We have some blood gas numbers for anybody who knows how to interpret those. They are surprisingly good for somebody who has had 4 hours of CPR, and that's an understatement. She gets rewarmed on the ECMO machine. So this is a special kind of heart-lung bypass. So not only is she on a ventilator, but she's also on a machine that takes the blood out of her body, it oxygenates it, and then it puts it back into her body at high pressure like your heart would. So we're substituting for her heart and her lungs. And she's rewarmed very quickly, and then we get her heart restarted. Not surprisingly, it takes more than just a couple of hours to get her able to function on her own, though. So we keep her on this heart-lung machine for about a day, which normally it's surprising that she wasn't requiring it for longer. And then it's also quite surprising that she was able to be weaned off the ventilator and basically breathing on her own and alive on day 3. And really, I heard she was kind of ready for the ward on day 4 or 5, but everyone felt like, well, we just got to keep her a little longer because she was just on ECMO and dead for so long. Okay, let's go back to that for a sec and check in with people about questions.
No questions in the chat at the moment.
Jenny, you got anybody who wants to say anything or wants to ask a question?
Questions, anyone? I think we're question free at this point, Doug.
Okay. All right. Well, that's a spectacular case. And now we're going to change gears for a minute and we're going to try and understand who is cold and dead, right? Because that is a really important skill. Because we don't want to try and do a resuscitation like we just talked about for a patient that has no chance of a good recovery.
Yeah.
One question here.
Sure.
Does epi have a place in hypothermic arrest, or is the 3 epi dose algorithm mostly because we don't know true temperature?
Yeah, great question. Um, the literature on different drugs in hypothermic cardiac arrest is a bit mixed. And in general, unless you're a big believer in the dog studies, my sense is that there isn't a large role for the vasoactive medications in hypothermic cardiac arrest. The reason we have the algorithm be for you to run 3 rounds of CPR and do all your normal things is really to both decrease the cognitive load and to try and pull out patients who have a different cause of cardiac arrest. And yes, generally, you're not going to know an exact core temperature until quite a bit later in your resuscitation. So it's mostly about doing what we usually do for 3 rounds. And the idea being that by the end of the 3rd round, you have to make a decision. Do I think this is hypothermic cardiac arrest? In which case, I'm just going to do high quality CPR and see if I can transport to an ECLS center. Or do I think this is not hypothermic cardiac arrest? In which case, I might go down a different termination of resuscitation algorithm. But we're getting ahead of ourselves because we're going to talk through a lot of that. But
One more
hopefully
question.
yeah, go ahead with the next question.
Is the idea behind the success of this resuscitation is that the metabolic needs of our brain and other organs are lowered during severe hypothermia?
Yeah, great question. And we are also going to talk about that. So I'm going to put that one on in the parking lot. But you are definitely on the right track. Why in the world can these people survive 4 hours of CPR? It is because the cold brain does not die quickly, and we'll talk more about that soon. Okay, let's talk about who's cold and dead. So it's tricky, and it's particularly tricky because hypothermia mimics death, and especially if you have a physician who, has a lot of experience in hospitals and things like that and gets relatively comfortable with their ability to pronounce people dead. And if they, for some reason, do not know about the special circumstances of hypothermia, then they can easily be fooled. Because hypothermia it's different for everybody, but below around 27, 26 degrees Celsius, it causes fixed and dilated pupils, but does not mean the patient has brain death. It causes stiffness that is not rigor mortis, but occasionally people who don't really understand what rigor mortis feels like wonder if the stiffness is rigor mortis. It will cause respiratory depression and then respiratory arrest, and then it'll cause cardiac arrhythmias. And even asystole, so a total flat line, is not a prognosticator of a dismal outcome when it comes to hypothermic cardiac arrest. So it basically takes away all of the usual clinical markers of death. And so what are we left with, right? And it's a kind of a classic medical student joke. What you're left with is history. And what you really need to understand for these cases is you need to understand the history. Did this person die and then get cold? In which case, with very few exceptions, they are dead. Versus did this patient slowly get cold? But while they were slowly getting cold, they were able to breathe oxygen and they were keeping their brain and their organs alive. And then they got to a very cold temperature, and at that cold temperature, they had a cardiac arrest. That's kind of what we're looking for. But in terms of who can you feel comfortable that is cold and dead if you very clearly know they died and then got cold. If their core temperature is too high, above 32, then hypothermia is not really on the menu, even though they might feel a bit cold. It's not the cause of their cardiac arrest. If you've got Han Solo frozen in carbonite, I would love one day for us to figure out how to resuscitate that person, but it would be a case report, so probably you can feel comfortable stopping. And then laboratory markers are tricky. A serum potassium greater than 12 is generally thought to be consistent with irreversible death, but we'll talk a little bit about that later, I think, on one of the slides. That it just really goes to show is you don't want to make life and death decisions off a single lab value, because you can occasionally get lab values that are what we call hemolyzed, and one of our cases has that. And then special circumstances, trauma, drowning, and avalanche, we're gonna tease apart separately, okay? So this slide talks to the question that one of our audience had, and that's what happens to physiology as you get cold. And this is particularly the cerebral oxygen consumption of the brain. So how much oxygen do you need to keep your brain alive? And the colder you get, the less oxygen your brain needs to stay alive. And there's a couple of temperatures that are really kind of exciting. The 50%, at 28 degrees Celsius, you need about half the normal oxygen delivery to your brain to keep your brain alive. And what's kind of exciting about this is that good quality CPR provides about half the normal cerebral blood flow. So in theory, if you manage to get yourself to 28 degrees without having any hypoxic brain injury, and then you have a cardiac arrest, and then somebody starts CPR right away, we don't actually know how long you could survive for. The world record's 6 hours or 6.5 hours, but we don't actually know, because in theory you're providing enough oxygen to keep the brain alive even with CPR. And then I don't think it's on this slide, but around 22, 20 degrees is another interesting temperature marker, because that is the temperature that we do these, not we being me, but the medical system does these interesting surgeries where they take these young kids who have terrible cardiac defects, and instead of putting them on pump, they just cool them down to about 20 degrees, and then they stop their heart, and then they do the surgery really fast. And as long as they do the surgery in under about 30 to 40 minutes, and they have the temperature under about 22 or 20 degrees Celsius, these kids have cardiac standstill with no oxygenation to their brain for 30 to 40 minutes, and then they fix their heart, and then they heat them back up and wake them up, and these kids do fine. And so the two numbers that I find very interesting is this 28 degrees, where CPR all of a sudden can keep you alive. And then as you get really cold, you can start tolerating prolonged periods of no flow, as long as you can be resuscitated in a way that you don't have an injury during the rewarming. But like we talked about before, the cold is not all good. In fact, when you think about all the other organs, the cold is very problematic. It's problematic for bleeding. And so your trauma patients, if you let them get cold, they're going to bleed like crazy, which means if you have a small liver lac or a small spleen lac, that maybe you could have, managed this patient in the golden hour, 1 to 2 hours to hospital, and then maybe get them to the OR and have a surgery. If you deliver that patient 36, 35, 34 degrees Celsius instead of 37, that patient may bleed out before they get to the surgery, or they may get to surgery, but they'll be unable to control the bleeding. So um, the cold is bad for your blood clotting. And then it's also your heart is very irritable when it gets cold. So the colder you get, the more irritable your heart is, and the more likely it's going to go into these malignant arrhythmias like atrial fibrillation, ventricular tachycardia, ventricular fibrillation. And when those things happen, the heart eventually stops. So it's tricky. The cold is very helpful for the brain, but very bad for all the other organs. Okay, let's pause. See if there's more questions.
Nothing at the moment.
Okay.
Yeah.
All right. So this case is a Pemberton SAR case, and this is on the road from Lillooet to Goldbridge. And this was unfortunately a public health nurse who was driving this road uh, in winter. Nobody witnessed her going off the road. There was a highways person who came along and just noticed the tire tracks had gone off the road. And so he um, got on his sat phone, told his dispatcher, "Hey, I'm just going to go poke my head over the road. It doesn't look good. There's some tire tracks and there's this huge slope." And so he poked his head over the road, and then he got his rope out, and then he went down a little ways, and then this is what he spied. And then very tentatively, he said, "Hello." And then someone inside the car yelled back at him, "Help." So you can imagine he was very surprised. Now, let's take a moment here because there's a lot of SAR nerds around, right? Now, tell me, SAR nerds, what are the technical skill sets required in broad strokes, right, to be able to effect this kind of rescue? What do you got?
Well, road team and Swiftwater team.
Okay, so you got AutoX, you got Swiftwater. Keep going.
Well, medical.
Yeah, advanced medical.
We heard road. Yeah.
I didn't hear it.
Oh, road? Did you not hear? Sorry.
Yep. So embankment, right? What's on the ground?
Avi's one that's
No.
listed on the
Yeah.
chat.
Avalanche. And then let's throw flat ice in there. And then presumably, unless you're going to do it all as a big rope rescue evolution, you're going to need helicopter rescue as well. Does anybody know anyone in the world who has that skill set? It's interesting, right? You can't call 442. They don't have all those skills. But if you put the firemen from Pemberton and the helicopter people from Whistler and the avalanche people from Whistler, you actually get this skill set, right? It's totally incredible. It's like some sort of Calvin and Hobbes super SAR scenario, right? Um, and interestingly, so Brad was the SAR manager on this case, and he got the information from the field, and he was immediately on the phone, like rallying his resources, and his team was flying up, picked up some AutoX people from the Pemberton team, and he's on the phone asking BC Ambulance to get a critical care helicopter on scene. And this case happened long enough ago that we didn't have auto launch criteria based on mechanism. And the response from BC Ambulance dispatcher at the time, who, wouldn't put him through to a supervisor kind of thing, was, well, the patient's awake and alert based on what we've heard, and there hasn't been a provider that has been down to them to assess if they're really injured. So we can't dispatch an air resource. And, you can just imagine Brad, he's very he's not the most diplomatic when he gets excited, right? So, anyways, he is yelling and screaming the whole way to come do this rescue. And when they arrive, there's a BLS crew from Lillooet on scene which, is fantastic, but is maybe not the exact resource that you would want. So this rescue actually goes very well. And while they are doing the rescue, BC Ambulance does dispatch a helicopter, interestingly, from Kamloops, because this particular point in the province is just actually perfectly equidistant by flight from VGH and from the Kamloops Hospital. But technically, I guess the closest, the ambulance station or was in the health authority that was represented by Kamloops. This will you'll see why this is important later. Anyways, so they arrive on the roadside. They get their rope access equipment. They secure the car. They get their flat ice spine board, floating spine board, everything. They get the door open, and when they open the door, they meet this woman who's still awake and alert. She has a facial smash, but is like talking to them through her facial injuries. She's up to her waist in ice cold water. And they managed to, as I say, open the door, cut the seatbelt, put her on the floating spine board, move her out of the vehicle, and then long line her up to the road. Um, and then at the road, thankfully, at some point, the critical care helicopter arrives. She does have a cardiac arrest initially during flight, but they get return of spontaneous circulation, interestingly. And then unfortunately, they flew to Kamloops and not to Vancouver General, because Vancouver General is an ECLS site. It has the special equipment, this heart-lung machine, and Kamloops does not. And so she arrives in Kamloops Emergency Department. She then has another cardiac arrest. They determined that her cardiac arrest is a hypothermic cardiac arrest, and that despite her facial smash and her major mechanism, she doesn't have other life-threatening injuries. It's now dark, and the helicopter that they used to transport her is not a night flight capable machine. And so they are trying to decide if they're going to do a crazy road ambulance down to Kelowna, which is the closest ECLS center. That does not come together, and unfortunately, she died in the Kamloops Hospital. So, like a very powerful and amazing rescue, and very close to potentially a save, but unfortunately, we didn't quite have the chain of survival in her case to be able to make it happen. Any questions there before we move on to some management tips?
Nothing in the chat right now.
Okay. All right. I'm starting to feel a little old because this paper that we published, although it was very exciting, is now more than, well, I guess it's almost 13 years old. Thankfully, it's still standard of care. And essentially what we did when we published this review article was we teased apart a lot of confusion from the hypothermia literature and essentially proposed that simplified clinical staging was all you need to be able to decide what treatment to give your patients. And we also showed that it's safe and appropriate to, apply insulation and attempt rewarming for all patients. And that's what we would call minimally invasive rewarming. And we'll talk about that more in a minute. We also showed that the duration of CPR is not a predictor for survival for well-selected hypothermic cardiac arrest patients. And that is what really opened the door to this sort of treatment in North America. I learned about this care when I went to a conference in Europe. Interestingly, actually, Bruce Brink was the one who got me excited and got me invited to the ICAR conference in Europe. And that's where I met the people I collaborated with on this paper, and where I also met a woman who had herself been accidentally cooled in a skiing accident to less than 14 degrees Celsius and made a full recovery and presented her own case. And then the other thing we kind of showed was that patients who have cardiac stability, it's safe to minimally invasively rewarm them. And there's one caveat to that, which we've kind of discovered later, but we'll talk about when we get there. Okay, so this is the basic algorithm, and it is essentially what we also use to then create the BC guideline, which we'll talk about later. And it looks a bit complicated, but hopefully you'll agree that it's actually very simple. So your first step is to decide, is my patient cold? Okay. And if your patient feels cold or very cold, then you apply the algorithm. And then your second stop on the algorithm is, does my patient have vital signs? Okay. Yes or no. And so we're going to start with the cold patient absent vital signs. All right. And so for your cold patient with absent vital signs, do I have reason to believe that they have obvious irreversible death, right? They have been buried for a prolonged period of time in an avalanche. We'll talk more about avalanche later. They have been decapitated. You have a clear story that they died and got cold. No, in which case start CPR, prevent further heat loss, and then do your usual resuscitation algorithm. Okay, so first decision, should I start CPR? And then your second decision is, should I transport this patient to an ECLS center, or should I transport this patient to a local hospital, or should I contact my medical oversight and talk about termination and resuscitation? And so if you don't have a good history, so if you have a history of cardiac arrest before cooling, major trauma, witnessed normothermic arrest, or prolonged avalanche burial, then this patient is likely not resuscitatable, and you should consider either stopping or transporting to your nearest hospital, depending on what sort of medical oversight you have to be able to make those termination or resuscitation decisions. And otherwise, you should try and get to an ECLS center. If you still aren't certain, there's a few tests you can do. You can measure a core temperature and you want it to be below 32, ideally even into that 29, 28, 27 degrees where we're protecting our patient with our high quality CPR. If you have a critical care paramedic helicopter, you could do an ISTAT and measure a serum potassium because that can also help you prognosticate. And then once you've decided to transport, you want to basically just focus on high quality CPR and transport. Okay. Now let's switch gears and go to our cold patient with vital signs. Okay. And so for our cold patient with vital signs, it's basically just trying to determine their level of consciousness. Okay. If they have a normal level of consciousness, then they are essentially going to be a mild hypothermia. Versus if they have an impaired level of consciousness, they're going to be a moderate or severe hypothermia. And the moderate or severe hypothermia, you're essentially going to decide, are they stable or unstable? Okay, so if you have impaired level of consciousness, unstable vital signs, this is a very high-risk patient and you want to transport them to an ECLS center. If you have an impaired level of consciousness patient, but they have normal vital signs, then ideally you'd measure a core temperature, but if you can't measure a core temperature, you just have to deal with what you have from the clinical staging point of view. Okay, the exception to this rule is if you have a patient who is immersed in water, being very rapidly cooled. There are scenarios where, their brain essentially is still in the mild hypothermia world and their core is already in the major hypothermia world. And so the classic would be somebody who's, let's say, been treading water or hanging onto a kayak for 45 minutes in icy water, and they're still talking to you. By this algorithm, that would be a no impaired level of consciousness, a mild hypothermia, but those people with the severe cooling mechanism, you still need to treat them like they are very cold because they often change very quickly. Okay, so what do we do with our cold patient with vital signs? We do what we call active, external, and minimally invasive rewarming. So ideally, you want to get them out of the cold. Obviously, that's not an option for us a lot of the time. So I'm a huge proponent of bothy bags. Bothy bags are those little Scottish, basically tarps with that are in a sort of dome shape that 2, 3, 4, or 10 of us get inside, and we very rapidly create a microenvironment that brings the temperature up 5 to 6 degrees. And then we start delivering heat to our patient. So whether it's chemical heat packs, or electrical ones, or we are running a stove outside our bothy bag and firing hot water bottles into our patient. If they are not protecting their airway, you manage their airway. If you are in a setting where you're giving IV fluids, you just want to avoid giving cold fluids. You don't think about IV fluids as a way to rewarm your patient. It's more that you give them IV fluids if they need it for their resuscitation. And the fluids you give them, you don't want to be cold. And then bladder lavage isn't really relevant, but we do that in hospital, and it's very effective and minimally invasive. And then ideally, we're going to have them on cardiac monitoring, particularly the ones who have an impaired level of consciousness. When we see these patients and we do have them on a cardiac monitor, their heart will usually be a bit slow, bradycardic. Blood pressure will usually be a bit soft, hypotensive, and they may or may not go into a funny rhythm called atrial fibrillation, where their heart goes a bit fast and a bit irregular. But those are not really a marker of impending badness. But if instead we're seeing ventricular arrhythmias, very low blood pressures, or very low core temperatures, these are the people that really are likely to arrest at any time, and we ideally would transport them towards an ECLS center, because when they do arrest, we're going to wish that we were in one. But that's a decision that basically the medics and the managers make together with the BC ambulance dispatcher and the EPOS physician. This isn't particularly relative to our world, but it was sort of asked about what's the role of epinephrine and other vasopressors in hypothermia. The thing to realize is that hypothermia causes massive vasoconstriction, and so you don't really get any additional vasoconstriction by adding a pressor, and those pressors generally cause more myocardial irritability, and your heart is already very irritable by being cold, and so the amount of benefit you're likely to get from that epinephrine or another vasoconstrictor, I think, is outweighed by the potential harm of precipitating a malignant arrhythmia and putting the person into cardiac arrest. This is different if you've been working on the person for a few hours, you've been rewarming them nicely, and you're starting to get some rewarming induced vasodilation. In that case, there might be a role for pressors. And then anytime anybody's thinking about pressors, you need to be very careful if the patient also has frostbite, because your pressors are going to make your frostbite worse. Okay, that was a lot. Hopefully we didn't lose too many people in the medical jargon and mumbo jumbo. Any questions before we get on to our special circumstances?
Nothing at the moment in the chat.
Okay. Trauma, drowning, and avalanche. Here we go. So I think we've already kind of hit this one pretty hard. Trauma and hypothermia is a lethal combination. Do everything you can to maintain and or improve your patient's temperature during your packaging, transport, and getting them to hospital if they are a trauma patient. Cold water drowning. This is where history is really the most important thing, okay? And I like to break drowning, quote unquote, up into submersion and immersion, okay? And submersion is kind of what we think about with drowning, right? The person goes under the water right away. They have a hypoxic cardiac arrest because they can't breathe underwater, and then they get cold afterwards, okay? Versus immersion. Immersion is these needle in a haystack that we're looking for, that maybe we can do these prolonged resuscitations and have a good outcome for. So an immersion story is somebody who is immersed in cold water, but still has their head out from water and is continuing to be alive and breathing, right? So this is your person in a life jacket. This is your person clinging to an object. This is maybe your person who was in a vehicle, who went underwater, and the vehicle slowly filled with water. That is, again, pretty rare, that the vehicle would fill slowly enough that they can get hypothermic before they have their cardiac arrest, but there have been a case or two of that in the literature. Okay? So in general, particularly for adults, if you have a history of submersion drowning, that person is probably not resuscitatable. You would likely do your 3 rounds of CPR, and if you don't get a return to spontaneous circulation, like, oh great, we just resuscitated our drowning patient, then likely you're going to shift gears to get some assistance for termination resuscitation. Versus if we think this is an immersion patient, like they were clinging to a log, getting cold, and then had their hypothermic cardiac arrest and then slipped under the water, this is the person that we really should maybe think about doing a full court press, prolonged resuscitation, and transport. Pediatrics, little small children, small humans, throw a little bit of a wrench into this, and that's because of a few things. They have a very small body and surface area, therefore it allows them to cool very quickly. And they have very plastic and resilient brains. Okay, so peds are a little bit of a special circumstance. And if you're dealing with some sort of pediatric case, make sure you call, make sure you get help from all the smart people you can access, EPOS, BC Children's Hospital intensivists, etc., who are going to help you make this decision. And the reason is this case, like the one I highlighted at the bottom, this is the craziest case in the literature. This is a 2.5-year-old kid who was witnessed to fall into a 5-degree creek and be immediately pinned underwater, and was underwater for 66 minutes until they turned the dam off and made this creek go away. And then they pulled this kid out. They started CPR. They transported to an ECLS center. He was 19 degrees and in asystole. They put him on a heart-lung machine and he made a full recovery.
I got
Okay.
one question for you,
Yeah. Go
and I
ahead.
have a feeling we got a few medical people here because they're asking some good questions. Is the addition of a PEEP valve at 5 centimeters still beneficial for post-arrest patients who are severely hypothermic?
Yeah, good question. What to set your PEEP at? I think a PEEP of 5 is very reasonable. Um, if you don't have a PEEP valve and you're just going to vent them with without PEEP, I think that's fine. And there isn't literature to support anything one way or another. In general, if your problem is really hypothermic cardiac arrest, oxygenation is not your big problem until later. After you rewarm them and restart the heart, generally they're going to go into ARDS, so like acute respiratory distress syndrome, and end up with bilateral whiteouts and be hard to oxygenate. But during the initial resuscitation, you shouldn't really have any difficulties oxygenating them. So I think PEEP of 5 is very reasonable, but I don't have any literature to support that. Any more questions there, Dwight? These are great questions. I love them.
No, one that came up is an immersion example would be Jack on Titanic.
I haven't actually seen the movie, but people ask me that over and over again, and my sense is you are correct. And I'm again going to put it on my homework because I think that's probably the third or fourth time I've been asked that question. So I
Oh,
apologize.
there is one that kind of popped up here. For a long time, people were worried about rapid rewarming for fear of afterdrop, collapse, arrhythmias. Is there any clinical significance to this fear, or can we put it to bed and aggressively warm people up as best we can?
That's a great question. I'm trying to remember if I have a slide on it at some point. Um, and I'm just gonna let me just tell you about this slide for a quick sec. Tipton is really the resuscitation in drowning kind of world literature guy, and I don't really agree with his approach. He has a really temperature of water and duration of immersion or submersion approach, and I'm much more of a fan of trying to tease out the history. So I'll just explain that slide. I'll go back for a sec. And we'll talk about after drop and rate of rewarming and things like this. Um, this is a tricky and controversial topic. And you will notice there's a lot of wilderness medicine literature that has highlighted and focused on after drop and the concerns around after drop. And I'm very torn in how to speak about this. And the reason is, so Gord Giesbrecht is a incredible Canadian physiologist who has done an enormous amount of work in hypothermia. And he has done these fantastic studies that essentially have demonstrated that after drop is a real thing, right? So he takes these patients and he cools them, and then he starts to exercise them, and their core temperature goes down by another 0.5 to 1 degree before the core temperature starts to come up. Okay. And so after drop is real. Um, how clinically significant is after drop in the context of resuscitation for hypothermic cardiac arrest is where we have had a few significant disagreements over the years. And what I can tell you is nobody would recommend that you go and drop your patient into a hot tub, okay? You certainly do not want to have massive instant vasodilation of the extremities, and then that would be very disruptive, okay? But everything that I have been able to look at in the literature has told me that if you do minimally invasive rewarming for your hypothermic cardiac arrest, that you are doing the best treatment you can possible. Because if you instead are shy about rewarming, in fact, what's going to happen is their core temperature is going to continue to decrease, and in decreasing their morbidity and mortality is going to continue to increase as well. And so, yeah, historically there was this fear if you started rewarming and you did it in the wrong way, could you get cold blood rushing back from the heart and causing malignant arrhythmias and making your patient sicker? And as long as you're doing minimally invasive rewarming, I believe that is not a risk at all, and the literature would support me. Um, Unfortunately, or fortunately, the physiology studies can't do any testing down into the core temperatures that we're talking about. So I don't know how relevant the after drop literature really is. And the fact is, as long as the extremities are cold, they're profoundly vasoconstricted. And so it takes a long time to overcome that vasoconstriction and to start circulating the blood back. So that's a long answer, but essentially what I say is that it's safe to rewarm your patients. You should try and quote unquote aggressively rewarm your patients, but what that looks like is like hot packs, electric heater, blankets, bear huggers, but not water immersion. Okay. Is there more questions, Dwight?
Nope, not at the moment. And
Okay.
thank you for that.
Avalanche burial. This is an outdated slide, but it is also a helpful one because by explaining the outdatedness, it sort of tells you about some of the controversies of this. So if you are buried in an avalanche, it's actually a very ineffective way to cool, right? It's not like being in a river or even being lying outside on the snow with wind blowing over you. Being packed in snow, surprisingly, especially if you're wearing some insulated ski equipment, ski clothing, and things like that, you cool very slowly. And so it actually, for most people, takes a very long time to get to 28 degrees or lower, which is kind of, well, below 30, but really below 28 is where we would love you to be before you have your hypothermic cardiac arrest. And so most people who come out of an avalanche dead have died either from trauma or asphyxia. And the number of people who have a hypothermic cardiac arrest who are buried in an avalanche are essentially zero unless you have some very special circumstances. And so the cases where we have had hypothermic cardiac arrest are people who are buried in what I would call a cavernous air pocket. So somebody who's thrown into a crevasse and then the avalanche buries them over top in a crevasse. Somebody who's buried in a building, somebody who's buried in a train, somebody who's buried in a vehicle. The other unusual ones we've had are somebody who has an air connection to the surface. So we had a patient who, not we, but the world literature had a patient who had their arm out to the surface, and then presumably that arm, their air pocket had connection with the surface, and so they had a hypothermic cardiac arrest and were successfully resuscitated. Other patients that I would be interested in are those who might have an avalung, right? So that they potentially have an ability to breathe while being buried. those would be the patients that would increase my spidey senses for a potential hypothermic cardiac arrest in the context of avalanche burial. ICAR has taken a slightly different approach, which is not an approach that I agree with. But basically, their first approach was to find the person who was the world record fastest cooler in an avalanche. And so they found this person who was in skin tight clothing, was sweaty, got buried in an avalanche for 35 minutes. They didn't actually have a hypoxic arrest or a cardiac arrest. They were actually still alive when they came out. But they had cooled fast enough that, sorry, they weren't under for 35 minutes. They were under for a different amount of time. But when they extrapolated the rate of cooling, they discovered that if you were to cool as fast as this guy cooled, then in 35 minutes you could get below 32 degrees. So their original rule for ICAR was less than 35 minutes of burial. If you came out dead, hypothermia wasn't a possibility because you haven't had long enough to cool. And so what they did was for 10 years, they took all of the all the people who were buried in an avalanche who were extricated greater than 35 minutes, and who didn't have obvious trauma as the cause of their death, and they took them all to ECMO centers and they resuscitated them, and they had 0 survivors. Except for the special circumstances that we talked about. But if I'm correct, I don't think any of those special circumstances were in that data set. And so then they were like, well, we're doing too many bad resuscitations, so let's just make it a little longer. So then they decided to use 60 minutes instead of 35 minutes. But again, it's not based on the history, it's just based on some extrapolations. So for me, the most important thing that somebody who is coming to an avalanche extrication can know is as you get close to the face, and as you open that part of your dig, I would love to know if they have a cavernous air pocket. I would love to know if they have an avalung in place. And more than anything, I would like to know if they have any signs of life as you extricate them, right? Because your best case scenario would be this person who's in an avalanche, who's somehow managed to stay alive because they have a big enough air pocket. And then you notice that they have some signs of life. And then as you dig them out or extricate them, they go into cardiac arrest. That is your absolute best chance of a good survival. You start high quality CPR and you arrange transport to an ECLS center. So that is the case that I think is the most likely to have a good outcome. And that's what I wish the rescuers were looking for. And then beyond that, I'd be very interested to know, is there a cavernous air pocket? Is there a connection to the surface and these other markers that might suggest the possibility for survival with the prolonged resuscitation?
One question for you.
Yes.
We are told to use caution when providing O2 to drowning cold patients. Can you elaborate on why and whether this is still relevant?
Great question. I'm not a drowning expert, so I do not know the answer to your question. If I were to guess, or if I were to think about what some of the issues are, some of the issues are we don't like hyperoxia, right? And so in general, anytime you're titrating oxygen for a patient in like a field setting and stuff, ideally you'd have a pulse oximeter on, and ideally you'd target like less than 97 or 98%. You would not want to target like a 99 or 100%. That being said, a lot of times our patients are cold, they're poorly shut down, they're peripherally shut down, and the pulse oximeter isn't going to read very well. So I don't know how practical that is. And then moving on to the specifics of the drowning, certainly there's lots of issues with drowning around surfactant, but I do not know anything about if there's any issues around oxygen and surfactant. Do we have anybody in the audience who is more well-read on the drowning literature and has any insight into that question? Because I really don't know.
I'll let you know if someone pops up here.
Okay, sounds good. Any questions around the avalanche issue? Because that one is, I think, quite important, and it's on my list of things to do is to try and advocate for easier to understand and more clear recommendations for avalanche rescuers, but it's not something that I have been successful or done yet.
Nothing in the chat.
Okay.
Oh,
All
hang on.
right.
Someone is answering. I think it's dealing with the O2. It's worse in saltwater submersion than freshwater due to sodium.
Okay. Something to read about.
Yeah.
Okay. We've basically covered all our material here. Um, we do have a BC clinical practice guideline. It looks very similar to the New England Journal. I think you guys are all pretty familiar with our logistical challenges in British Columbia. Um, it's fun when I have presented this work in Europe because our province is the size of Germany, Austria, Switzerland, and Italy combined, and we only have four ECLS centers. Um, and you can imagine each of those countries has literally dozens of ECLS centers. It's challenging. But for us, we have Royal Jubilee on Vancouver Island. We have Royal Columbian in Vancouver General and St. Paul's in Vancouver. We have BC Children's for the small adults. We have Kelowna General. And then we also have some agreements with Edmonton and Calgary that patients from the Kootenays can go there potentially for care. I won't talk too much about how the guideline came together. And then if you want to look at the guideline, you can go to drdougbrown.ca and you can look at the guideline and New England Journal and listen to podcasts and do all those sorts of things. This, I think, is an interesting slide because it really tells people some practical information about how to um, create a good burrito for rewarming. And I think this is very practical for SAR. Um, one of the questions we always get is, should we take the wet clothes off or should we leave them on? And people in Scandinavia actually have done some really great pre-hospital care studies on this that I'd recommend reading if you're super keen. But the short answer is you can do either one. If you're going to leave the wet clothes on, what you need to do is to have a vapor barrier immediately outside the wet clothes. So if you're going to leave the wet clothes on, basically you need to pull a garbage bag up to their neck and seal it with as little space as possible. And now essentially the humidity will go to 100% instantly, and you're not going to lose any more heat to the person having to evaporate the wet clothing. And so you've effectively stopped the heat transfer from the evaporation. Obviously, it's much less comfortable for your subject than if you had gotten them out of their wet clothes and didn't have to put them in a plastic bag. So there's a comfort difference between the two options, but from a heat management point of view, if you can do a vapor barrier, you don't have to take off the wet clothes. So either dry clothes or wet clothes with a vapor barrier. The next thing we're going to do is our heat source. And so you just need to make sure that it's not going to burn your patient. And then the next thing is you're going to do some insulation. And then ideally, outside of that, you're going to have both a windproof, waterproof, and also a reflective surface that is going to keep all the heat inside and prevent further heat loss. So that's how you make a great burrito. And I know there's lots of expertise on your teams around this, and this is something that every SAR responder should practice at least every couple of years and make sure that they have stuff in their kit that they can do on an improvised level. And then obviously your teams need proper hypothermia kits as well. But don't just rely on somebody else bringing the hypothermia kit. Every hasty team has to have enough to be able to deal with a patient who can't manage their own heat, right? So if you're stuck with a patient for half hour, an hour, or more, you need to be able to insulate them and deliver heat. Any burrito questions before we keep going?
Nothing yet.
Okay. This is just a little slide to remind everybody how hard it is for change in healthcare and in search and rescue. It takes a long time. This is a little summary slide. Oh, did I take out the slide where I proved to you that I'm gonna just bring up the hypothermia mass casualty first before we So this is the slide where I get the confidence to be able to tell you that the survival is 50 to 100% in well-selected patients. And this is a rescue from 2011, and it was in a place very similar to Vancouver. It was it was a Danish accident, and it was 13 teenagers, 2 adults. They were out dragon boating. The boat swamped. Um, one adult took off his life jacket and tried to swim for shore, and he died. And everybody else remained with their life jackets. There was one of the children who made it to shore with the life jacket, activated help, and then collapsed. That child actually, instead of going directly to the ECLS center, went to a peripheral hospital and then later went to the ECLS center. And interestingly, that was the one patient with significant cognitive impairment. But for all the rest of the patients, they essentially had one rescue helicopter that was pulling these kids out in singles. They had one hospital where they were taking all these kids to, and they rewarmed the 7 cardiac arrest patients in sequence using 3 operating rooms over the course of several hours. And they had 100% survival, despite 7 of them being in cardiac arrest on presentation. And all of them had a good outcome except for one. Everybody else is at grade level. Okay. So let's go back to our summary. Yeah, so my summary really is protect the temperature, take the temperature control seriously in your trauma patients. Okay. If you receive that patient at 35 degrees, I want you to deliver them to the hospital at 36. Okay. And I do not want you to lose a few degrees on the way because you don't have the equipment or you're not careful. And then for patients in cardiac arrest, high quality CPR, determining that you think this is a hypothermic cardiac arrest, and then advocating for transfer to an ECLS center. The BC guideline says that up to 6 hours of CPR is reasonable. So if you have a case that has logistics that can see you at an ECLS center within 6 hours of CPR starting, and you truly believe that this is a hypothermic cardiac arrest, then that's reasonable. If you're in a situation where you're looking at 8, 10, 12 hours, longer of CPR, then potentially you should think about going to your local center. And again, if it's a child, you're going to want to really bring in some experts to help that decision. And then the other point is really just that this chain of survival is delicate. And so you really need to educate yourselves, which you're doing, but then you also need to reach out to your paramedics that you work with, and then the docs in your hospitals as well, to make sure that everybody's kind of on the same page so that if and when one of these miraculous cases ends up in your lap, that you're kind of ready to care for them. And so, how are we doing for time, Jenny? Should we play the little video that makes us all feel good about the care that was provided to Christine Newman, or are we almost out of time?
I would play it. You got a couple minutes. Yeah, you're quarter after.
Okay,
We like
Jenny,
to feel good.
thumbs up from Jenny. Okay, here we go.
They actually kind of chip her out of this hole. She actually frozen into the hole, and her body temperature when she went in, it melted the ice and then it refroze, and it took all those people for quite a while to chip her out.
That Christine Newman is alive at all is a miracle. On Tuesday, she was pulled from a tree well near Elfin Lake, north of Squamish. She'd been there for more than 5 hours and showed no signs of life.
Every step of this process was flawless. The people that were doing the CPR knew what they were doing. They never stopped once.
As I got information from the field, it became apparent to me that this woman fell into a really rare situation where we believe she was in cardiac arrest because of the hypothermia.
Hal immediately called Doug Brown, an ER doctor who's been studying accidental hypothermia for 5 years. He also knew all of the doctors, specialists, searchers, and paramedics needed to save Newman's life. He happened to be out for a jog, but luckily had his cell phone and admits the stars aligned.
essentially, as soon as they grabbed her and pulled her out of the tree well, the clock is ticking. Luckily, they started CPR right away. And then because she was cold is the reason that she can survive many hours of CPR without a bad outcome.
Newman survived after 4 hours of CPR. Brown says that's a record, the longest ever in North America with a positive outcome. He also convinced the ambulance supervisor to fly Newman to Vancouver rather than transport her to Squamish, another life-saving decision.
If any one of those steps would have broken down and people wouldn't have been thinking ahead, then yeah, she wouldn't have survived.
Newman was warmed up by a highly trained team using a device called an ECMO, a heart and lung machine found in only 5 hospitals in BC. She's expected to make a full recovery.
She doesn't even have a broken rib or a bruise. Her fingers are pink and her toes are pink. They did such a fabulous job.
You know, this is a once in a lifetime call, and it's unprecedented anywhere.
While rare, it's hoped Newman's case will help change protocol and in turn save lives. Jill Bennett, Global News.
Yeah, one of the things that the Lucky Stars really, it was very interesting because when this case happened, we didn't have the provincial guideline approved yet, and we were actually at the stage where we were fighting a little bit over how long of CPR would be reasonable, because everybody was worried that, you know, we would place a big burden on the system and these patients might be on ECMO for days, weeks, or months. And anytime somebody's on an ECLS machine, they can't do the cardiac surgeries that normally use that machine. And so there was a little bit of pushback happening. And then this case happened, and this, you know, very successful rescue for a nice woman and her family. And she was only on ECMO for like 24 hours. And so this case happening at that time was also lucky stars for then being able to get the guideline approved and then to be able to sort of operationalize this care for BC for the future. So there was a lot of good things that happened as a result of some great rescue by Squamish SAR. So let's open it up for any more questions or discussion.
There's none in the chat, but if you have questions that you want to unmute yourself and ask Doug directly, now's a good opportunity to do that.
Okay, I have unmuted us in case anybody here has a question. Anyone? They're very quiet.
Do you have anybody in the audience who was on the rescue who wants to pipe up and let me know the parts that I got wrong, or just say something about that day?
I don't know if we do. Do we? No.
Yeah, I was around for that one. I wasn't on the call. It's Malcolm here. But I do remember, Doug, I wish I remembered the date because I think it was probably less than a week before you did this talk.
Yeah.
Which was pretty wild. Yeah.
Yeah.
I
really credit John Howe for getting on the horn for you right away. He's like, this is your talk, and saying that.
Yeah, there was a lot of lucky stars that lined up. I think it was more like 2 or 3 weeks, but it was like remarkably a short period of time after we'd had a session like this. And then the call happened. And then, yeah, those guys they just nailed it. They knew exactly what they were dealing with. And it was interesting, right? Because the BC ambulance dispatchers, none of them knew what, like the Squamish SAR team knew way more than they did, right? So it's interesting how that can happen sometimes.
I think that drives home the need to do make sure your training cycle has this kind of thing going into the winter season. And I know a lot of teams around the province have a hypothermia kind of training like this. It's good to keep your refreshing every time you come into a new season. What do you need to look out for?
Yeah, great point, Dwayne.
Oh, hang on. I missed something here. We got 2 new. I remember the talk also. You did not talk about keeping victims supine during extrication. Any thoughts?
Yeah, it's a very good question. Especially when extricating people from water. trying to maintain horizontal position, I think, is very important. And really in anybody, if you have people who are very cold, you want to avoid rapid changes in posture, with the worry about changing just slight changes in pressure might, in the context of their irritability. So yeah, especially in water, if you have a severely hypothermic patient who you're extricating from water and you're able to, it would be nice to bring them out supine. If you have a crevasse rescue, there's some controversy about what to do. Certainly, my sense is if the patient is already vertical, then I think just extricating them vertical and dealing with the changing their posture when you're in a much less confined space, I think is very reasonable. There's other people who would advocate for treating posture much more aggressively and even in the crevasse, like rotating them into a horizontal posture. But I'm more on the don't do rapid changes versus necessarily being wanting to really prescribe that people have to be so scared of posture um, or really a lot of these times you just need to do the best you can. And if the patient does go into hypothermic cardiac arrest, then you want to resuscitate them and transport them. So yeah, I like to not try to add too much complexity, but it's a good point, especially for water patients. If you have the opportunity, bringing them out supine is a good idea.
Doug, I think we're at the end. I see you've got some information there if people need to reach out to you with any questions. This is being recorded. We will have it on our website in the next week or so. And I do appreciate everyone showing up tonight. And Doug, your obvious expertise on the subject is very appreciated sharing it with the SAR community. Thank you.
Awesome. Thanks so much, guys. It's really a privilege and a pleasure. And yeah, spread the word. As I said, there's some resources on my website. This talk will now be on the BC SAR Support Network website, which is fantastic. Hopefully, other SAR teams will be able to have access to good information. And yeah, I look forward to the next time I get to get involved with a Squamish call or any of the different mutual aid calls. It's always such a pleasure to meet everybody and work together on these cases.
Take care, everyone, and be safe.
Thank you very much.